We are live.
So, good evening, postgraduates, and my regards to all the mentors. Welcome to this 117th episode of All India Ophthalmological Society's Academic and Research Committee's PG teaching program. This is a signature program of Academic and Research Committee initiated during our tenure. We are very happy to invite you for this 117th episode. And today's episode, we will be having two short cases. The first case is going to be on cataract with pseudoexfoliation, and the second is cataract along with diabetic retinopathy. So, without much ado, can I request today's moderator, Dr. Anaga Heru, to carry forward the proceedings? And my sincere most thanks to all the mentors as well as all the examiners who have agreed to spare their valuable evening for our postgraduates. Thank you. Anaga,
Yeah,
over to
thank
you.
you. Yes. Thank you so much, Dr. Prashant, and a very warm welcome to one and all in this AIS ARC PG webinar. So I'd like to invite our mentors, Dr. Manisha Nada, who is the Professor Pandit Bhagwat Dayal Sharma, Postgraduate Institute of Medical Sciences, Rohtak. Welcome, ma'am. And Dr. Nilima Mehrotra, she is the Professor and HOD of Sri Ram Murthy Smarak Institute of Medical Sciences, Bareilly. Welcome, ma'am.
Thank you.
And we have, thank you. And we have three esteemed examiners for today. Welcome Dr. Anil Tanwar sir. He is the head of department of Hindu Rao Hospital, Delhi. Welcome sir. Welcome Dr. Lognathan sir. He is the professor and head of department of Sri Venkateshwara Medical College Hospital and Research Center, Pondicherry, Puducherry. Welcome sir. And also
Thank
Professor
you.
Dr. Ragini Parekh from Manorama Netralaya, Mumbai. Welcome, ma'am. We have two presenters who are young and dynamic, and we wish you all the best. I'd like to call upon Dr. Akanksha Vai. She is the junior resident from Sri Ramurthy Smarak Institute of Medical Sciences, Bareilly, to give her presentation. You can please start sharing.
So, in the absence of one of the examiner, can I request the other mentor also to join as an examiner? We can be all an examiner. So, for example, for the first case, for Akanksha, I think Dr. Manisha can be the examiner and the vice versa.
Yes, that's a great idea. Akanksha, you can start, please.
Okay. A very good evening to everyone present here. Myself, Dr. Akansha, will be presenting a case on cataract with pseudoexfoliation under the guidance of Dr. Nilama Mehrotra, ma'am. This is a case of 82-year-old female who was a resident from Bareilly. She presented to her OPD with complaints of diminution in her left eye since past 2 years. Patient was apparently all right 2 years back when she developed gradual onset painless diminution of vision in the left eye, which was slowly progressive. There's no history of pain, watering, colored halos, photophobia, excessive lacrimation, no history of nausea, vomiting, or headache. There's no history of steroid usage, no history of any ocular trauma, and there's no history of spectacle use in past. Past history, there's history of right eye cataract surgery 15 years ago. In the systemic history, there's no history of diabetes mellitus, hypertension, any bronchial asthma, COPD, tuberculosis. There's no history of steroid intake, and there's no known drug allergy. And there's no similar complaints in the family. Personal history, patient is vegetarian by diet with normal bladder bowel habits, normal sleep wake cycle with no alcohol or tobacco abuse. General examination, patient was normal in appearance with average build, well cooperative, with no anemia, jaundice, cyanosis, edema, with the blood pressure of 120 by 80 millimeter of mercury, pulse rate of 82 beats per minute, with respiratory rate of 18 breaths per minute and afebrile on touch. Systemic examination was all within normal limit. Coming to the ocular examination, right eye visual acuity, unaided visual acuity in the right eye was 6 by 36, which was improving to 6 by 9. And in the left eye, vision was 1 by 60 with PL positive and PR accurate. There was no improvement. On retinoscopy in the right eye, there was plus 1.5 in the vertical axis and plus 0.5 in the horizontal axis at 2/3 meter directed with Tropac, and there was faint glow in the left eye. Extraocular movements were full and free in all gazes in both the eyes. Intraocular pressure by Goldman applanation tonometry revealed in right eye it was 20 millimeter of mercury, whereas in left eye it was 18. On gonioscopy, the angles were open in all the quadrants with sample-C line seen in all quadrants. Binocular examination, head position was normal, position of eyeball was normal, extraocular movements were full and free. Coming to the examination of the right eye, the eyelid and adnexa was normal. Conjunctiva and both the eyes were normal. In cornea, right eye was clear, whereas in left eye, the cornea showed few nebular corneal opacities. Anterior chamber depth was normal, deep with VH grade 4 in right eye, whereas in left eye, it was VH grade 2. Anterior chamber was quiet with normal depth and content. Orbital margins were all palpebral, regular and smooth. Iris in the right eye, normal color and pattern in both the eyes. Pupil was non-dilating pupil, 5 mm in size with sluggish reaction, and whitish fibrous structures were seen deposited over the pupillary ruff in both eyes. Whereas in the left eye, it was 7 mm in size. Right eye, there was shimmering reflex present. There was PCL in the back. Whereas in the left eye, there was cortical grade 3 cataract with nuclear sclerosis with dense posterior subcapsular cataract, grade 3. Fundus of the right eye was clear with tessellated background. Cup disc ratio was around 0.2:1. Vessels appear to be normal. Foveal reflex could not be appreciated. Peripheral retina appeared normal. In the left eye, the media was hazy. Background appears to be tessellated. Cup disc ratio appeared to be 0.4. Res details could not be appreciated because of dense cataract.
Akanksha, just a sec, please. Could you tell me again the findings of the lens on the left eye?
So left eye, the cataract was dense with cortical grade 3 cataract with the dense nuclear sclerosis and dense posterior subcapsular cataract.
And any thing on the lens surface, was it smooth or it had some texture?
So lens capsule did not had any finding. It appeared to be smooth.
Please go ahead.
And can you hear me?
Yes, sir.
Why you didn't see the four-wheel reflex in the right eye? What is the reason behind that?
So the background was severely tessellated, so the foveal reflex could not be appreciated much.
Is it absent or you could not able to appreciate?
Sir, I could not appreciate.
Okay,
Proceed, please.
please. Yeah.
This is the anterior segment picture of the right eye showing shimmering reflex was present, and this was the left eye showing dense cataract with the whitish deposits on the pupillary margin of both the eyes. This is the gonioscopy finding. There was visibility of sample C line in all the quadrant. This is basically the superior quadrant which I have captured. Case summary. This is a case of an 82-year-old female who presented to our OPD with complaint of diminution of vision in the left eye since 2 years. An examination, the right eye was 636 with pinhole 69, and in the left eye it was 1/60 with PLPR accurate. IOP of right eye by applanation tonometry was 20 millimeter of mercury, whereas in left eye it was 18. Pupils were not fully dilating, they were sluggishly reactive to light with the shimmering reflex in the right eye and dense cataract in the left eye. The left eye fundus was details were pretty hazy. Diagnosis. My patient is diagnosed as a case of left eye pseudophakia with the right eye pseudophakia with left eye dense cataract with exfoliation in both eyes.
So, what is your plan for management of this patient?
We are planning to cataract extraction would be the first plan for left eye, followed by since the IOP is normal, but later on there are IOP fluctuations in cases of pseudoexfoliation, so we will prescribe an anti-glaucoma topical medication to a patient for both eyes.
both the eyes. And
Yes.
any other investigations you'd like to do, and any other examinations you'd like to do pre-operatively, look for something in such a patient?
So we can go for endothelial cell counting because in pseudoexfoliation cases, the endothelial cell count is poor. Sometimes it is poor, so we have to plan the surgery accordingly. And we can go for ASOCT also to assess the actual depth of anterior chamber.
Anything else?
So we'll go for a detailed biometry to assess the lens thickness.
Anything else you would note in relation to the lens that you may encounter, which may be a source of complications or increased surgical time during the surgery?
So we should look for certain cases of pseudoexfoliation. There are chances that the capsule might be a little floppy, and that can lead to runaway of the rexes that can complicate the surgery. So we need to look for phacodonosis and status of the zonules.
Okay. If you notice phacodonosis, so how will it affect the planning of your surgery?
So if there is phacodonosis, then the rexes should be large enough to prolapse the nucleus so that the rexus doesn't extend and we might not end up in some complication during cataract surgery. And also we need to keep a capsular tension ring prepared before the prior to the OT so that in case the rexus runs away, then we can put a capsular tension ring and proceed with the surgery and put the PCR.
So will the capsular tension ring help with your capsular access or with something else?
Mm. So it will help in keeping the capsule tense so that we don't end up in rupturing the um,
So it will stabilize the capsular bag complex and prevent any further zonulolysis to occur with your manipulations of the with your intraocular manipulations. That's the idea, right? Okay.
yes.
Any other precautions that you'll take?
So during the surgery,
Yeah. Or while planning for the surgery?
How would you grade, Dr. Kansha, how would you grade the dialysis? That would help you in planning your surgery, whether you want to use CTRs or you want to use segments or want to use RSOPs. It all depends on the grading. So how do you grade that
according to
dialysis?
the clock hours, we'll grade the dialysis, as in how many clock hours are involved in the zonular weakness.
When do you plan for CTR? In what cases?
Ma'am, if there are more than 4 to 5 clock hours involvement of the zonular weakness.
You mean to say in moderate? You want to say in moderate cases? Can
Yes,
you use
ma'am.
CTRs in severe cases of subluxation?
Yes, ma'am. We can use.
What else can be used? How do you center the rexes in cases of dialysis? Dr. Kansha,
Sorry, ma'am.
where would you center your rexes in cases of pseudoexfoliation and there is dialysis? Should it be centered on the capsule or it should be centered in the pupil?
Ma'am, it should be centered in the pupil.
How much margin should be left at the equator, the least margin you can leave for anterior capsule in cases of CTRs. When do you plan for iris hooks, Dr. Kansha?
Ma'am, in cases of non-dilating pupil,
Yes, but
for
we are talking of dialysis, na? We are talking of pseudoexfoliation with dialysis. In what cases we should use iris hooks rather than using CTR? What is made up of? CTR is made up of what material?
ma'am, ma'am, it is made up of polymethyl metaacrylate.
What are the sizes available? Should you be examining the patient with dialysis in sitting or in supine position?
Um, in supine position.
Why should you do that?
Ma'am, to assess the amount of phacodonosis that it is leading to and to have a clear view of the severity of zonular dehiscence,
What
sorry,
else
zonular
should be taken
weakness.
care of while you are doing surgery in cases of dialysis? In a case of pseudoexfoliation, what you can find, what disasters can happen? You did a good Raxis, right? You have a moderate to severe subluxation. What else you can find on examination under microscope, which can bother your surgery? Can you think of vitreous?
Vitreous
Can there
prolapse.
be vitreous prolapse? How
Vitreous
do you
prolapse.
manage them?
Ma'am, we need to do a limited vitrectomy in that case, anterior vitrectomy of the prolapsing vitreous.
Good. What kind of IUL should be used
Is it,
in these cases? If there is dialysis, would you go for torics or you go for accommodating or you go for normal monofocals?
Ma'am, it is better to go for a normal monofocal lens.
Why?
Ma'am, because of the vitreous prolapse, there would be a constant push from the posterior chamber that will it might displace the lens position that we have aligned to. It will disturb the lens alignment.
You just give me what is the role of UBM in such cases of pseudoexfoliation? That's my last question. Then others can go ahead.
Ma'am, to look for the endothelial cells and to look for any pigment deposition on the anterior lens capsule also.
Dr. Tamar, Dr. Logan.
Lognathan.
yes. Can you hear me? Hello.
Yes, sir.
Is it a stationary or progressive condition? Pseudo exfoliation.
Sorry, sir.
Is it stationary or progressive condition?
Sir, it is a progressive condition.
What is the long-term complications when you do cataract surgery in this patient?
Sir, pseudo exfoliation, sir, since it is a progressive condition, there might be increase in the uh, production of the fibrinous deposits, which can later on occlude the trabecular meshwork, and patient might land up into and glaucomatous he might present to us again with the glaucoma with the increased IOP, and in acute cases, it can also lead to angle closure episodes. So if we are doing just a cataract surgery right now, then later on uh, he might need a trabeculectomy, or if the IOP is not controlled with medical management, then we might have to plan him again for surgery.
So what is the purpose of evaluating cardiac condition in this patient particularly?
So because in glaucoma, sir, we prescribe beta blockers also, which is contraindicated in patients having cardiorespiratory ailments. So it is important
Nice.
to
No, no.
ask for the history of.
Is there any association if there is a pseudoexfoliation syndrome and a cardiac illness?
Sir, in cardiac illnesses, if the patient is on antihypertensive medications, then he might land up into um, nocturnal crisis and nocturnal hypotension, which might lead to ocular ischemia, and his IOP might rise.
There is a close
Fluctuation of
relationship.
intraocular pressure is there.
Apart from this drug side effect, these patients are highly prone for myocardial infections and coronary artery disease. So you have to keep them watch. Okay, what other places we'll see the pseudoexfoliation material apart from lens and pupillary margin?
So it can be seen on the anterior lens capsule. It can be seen on the endothelium of cornea. It can be seen on the pupillary margin. It can be seen in the anterior chamber, on the trabecular meshwork, on the lens zonules,
Extraocular.
on the conjunctiva.
Any other organs gets involved in this pseudoexfoliation?
Sir, cardiovascular system is involved, and there are incidences of single tone hearing loss in patients of pseudoexfoliation syndrome.
So it involves other organs also, like gallbladder, kidney, liver, and also meninges and vascular endothelium also. So that's why these patients prone for ischemic heart disease. What is it actually, pseudoexfoliation material?
Sir, it is the extracellular matrix metalloproteinases that are in their abnormal metabolism leads to its deposition.
From where it comes?
From the extracellular matrix.
So basically it's from the aging epithelial cells. Okay. What is true exfoliation?
The true exfoliation are seen in glass blowers. There are actual white deposits seen on the lens material and on the capsule and the back of cornea.
So post-operatively, why there is increased inflammation in these patients? Following cataract surgery, you see the amount of inflammation is high compared to the normal individuals. Why?
So because since the pupil is not fully dilating, we tend to do some iris manipulation that leads to post-op increased post-op iritis.
In particular to the disease itself, is the disease causing any direct effect on such related to the inflammation?
Can you repeat the question? I could not hear it.
Like what you are saying, because of manipulation, it is inflammation is increased. Pseudoexfoliation itself can cause post-operative inflammation.
Yes, sir, there are incidences of increased inflammation in patients of pseudoexfoliation syndrome.
So it causes these patients, their blood aqueous barrier is already damaged. So we expect some kind of increased inflammation in these patients. Okay.
What kind of IOLs would you prefer for these patients?
So it is preferably monofocal IOLs are preferred. Monofocal rigid IOLs are preferred in these patients.
Can't you use monofocal foldable IOLs?
So we can use if the rex's margin is well maintained, then we can go for monofocal foldable also.
Any other attributes that you would like to have in your IOL?
Like you plan for any coated IOL. That's what.
Sorry, sir, which IOL?
Coated.
This is the clue for you. We plan for any coating in the over the IOL. Since we expect some kind of inflammation, we can get the deposits over the IOL. So we want to prevent that. So what kind of coating you plan for it? You have heard about heparin coated IOL?
Yes, sir.
Dr. Manisha, anything more that you would like to ask this candidate? You're muted, ma'am.
Yeah, I think she has presented well. She has answered many questions and she had prepared well. So I think I'm done with the questions for her.
Yes, ma'am.
Yeah.
The answer is a little bit nervous, I think. Maybe.
Yes, but she could
Yes.
answer. Good
Yes.
present.
Good presentation, Akanksha.
Thank you,
Presented
sir.
well. Nice presentation. Yeah.
Thank you, sir.
Dr. Anaga, please.
Any more questions? Can we move on to the next presentation? So
Yes, ma'am.
I'd like to now invite Dr. Kritika Jain, who is a junior resident at the Pandit Bhagwat Daya Sharma Postgraduate Institute of Medical Sciences, Rohtak, for her presentation. Thank you, Dr. Akanksha. That was a great presentation and great discussion.
Thank you, ma'am.
You can start your presentation.
Yes, ma'am.
Yeah.
Good evening, everyone. I will be presenting my short case on cataract surgery in diabetic retinopathy. Moving with the case, a 57-year-old female presented with
Please
a.
share your presentation.
I have shared my screen, ma'am. One second.
Yes.
Ma'am, is it
Make
visible?
it full screen. Yes.
Uh,
Yeah. Make it full
so,
screen. Yeah. Okay.
yes, ma'am. So, moving on with the case presentation, a 57-year-old female came with the complaints of diminution of vision in both eyes for the past 5 months, right eye more than the left eye. The history of present illness, the diminution of vision was insidious in onset and progressive in nature. There were no complaints of pain, redness, watering, photophobia, flashes, and floaters. The past medical history, patient was a known case of type 2 diabetes mellitus for the past 2 years and was on tablet metformin 500 milligram BD with irregular medication compliance. There was no history of hypertension, tuberculosis, asthma, cardiovascular event, or other systemic diseases. There was no history of steroid use. And the family history was negative for diabetes mellitus, hypertension, and other ocular disorders such as glaucoma. The general physical examination of the patient revealed that the patient was, at the time of examination, the patient was conscious,
So how did
alert,
you
well.
ask for history of, one second, how did you
Yes, sir.
ask for history of steroid use?
Uh,
The
so
patient is
basically, yes, sir.
uneducated, how do you ask for steroid use?
More usually when a patient, it can be seen in patients who have long-term chronic skin diseases. They are usually prescribed steroids, or could be any medication that he's been using for a very long time, prescribed to him by a local or a non-licensed practitioner. Could be steroids, sir.
History of any chronic drug intake.
Okay, sir.
And if you have specific systemic illness like skin disease or arthritis, you
Okay,
can
sir.
ask that.
Okay,
Yeah,
sir.
proceed, please. Yeah.
The family history was negative for diabetes mellitus, hypertension, and other ocular disorders such as glaucoma. At the time of examination, the patient was conscious, alert, well oriented to time, place, and person, was of average build. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. The vital signs of the patient were within normal limits, and the systemic examination was also within normal limits. On ocular examination, the unaided vision of the right eye was 560, which did not show any improvement with glasses, whereas the vision of left eye was 636, which improved to 612 with a correction of -1 diopter spherical lens. The adnexa, cornea, conjunctiva, anterior chamber, iris, and pupil were within normal limits. The lens was cataractous with a grading of NO, nuclearopelsins 4, nuclear color 4, and a cortical cataract of 3 and PSC 2 in the right eye, whereas nuclearopelsins 4, color 4, and cortical cataract 2 according to the LOC 3 classification. And the IOP measured using Goldman applanation tonometry was 14 mm Hg in both the eyes. This is the anterior segment image of both the eyes showing the optical section of the lens. The fundus examination of the right eye shows the presence of dot blot hemorrhages, exudates, and the presence of macular edema. Uh, and in the left eye, there were flame shaped hemorrhages, dot blot hemorrhages, and hard exudates, but there was no macular edema. The OCT was done for both the eyes. In the right eye, we can see there's an increased central macular thickness along with hyperreflective spaces are also present, and along with hyperreflected dots are also present. Whereas for the left eye, the OCT was normal. Later, the blood investigations were done. The blood sugar profile of the patient was deranged with an HbA1c level of 7.6%, and a random blood sugar level were 253 milligram per deciliters. The lipid profile of the patient revealed slightly higher levels of cholesterol, triglycerides, and lower levels of HDL. And in the urine, sugars were present and were 2 plus. So the initial management was done by referring the patient to endocrinologist for optimization of the blood sugar levels, and medications were modified to tablet metformin 1000 milligram BD and tablet vildagliptin 50 milligram BD. Was advised lifestyle modifications and was asked to maintain a random and a fasting blood sugar chartings. And the patient later followed up after 2 weeks with the fasting blood sugar levels reduced to 174 and was then planned for right eye injection ranibizumab. So the patient was given two injections, 1 month apart, and the OCT image on the right side of the screen shows is the OCT which was captured 1 month after the second injection, and the vision had improved to 636 from 560, and on that day the fasting blood sugar levels were 137, and the patient was planned for right eye cataract surgery with PCIOL implantation. And these are the anterior segment images for the patient on post-op day 1. And the visual acuity unaided was 612 and the IOP was 17 mm Hg. And the patient was advised strict glycemic control along with the other topical eye drops, including prednisolone acetate, moxifloxacin, nepafinac, and sodium hyaluronate. And then post of 1 month, the OCT for the right eye was repeated. And in this, we can see there is a normal central macular thickness and a single hyperreflective space is also seen. But not in the foveal area. And the vision was 6.9 and the IOP was 16 mm Hg. And on that day, also the fasting blood sugar levels were 109. And the patient was advised regular follow ups along with strict glycemic control. It's done, sir.
Perioperatively, what specifically you look for before cataract surgery among diabetic patients?
So in these patients, starting from the adnexa, we should always look for other adnexal blepharitis and everything, and cornea we should always check for sensations, and then we should look for the iris should be specially examined for any neovascularization, and then the posterior segment should be examined for the classical diabetic retinopathy findings. Sir.
Suppose you are planning for premium IOL in these patients.
Yes, sir.
So what are the parameters you look for in relation to diabetes?
Um, so in case of premium IOL, sir, I'm not.
Did you look for anything in the tear film?
Sorry, sir.
Did you look anything in the tear film?
Yes, sir. So these patients also are more prone to like dry eye disease. So the tear film adequacy should be checked, sir.
How diabetes induce cataract? What is the mechanism?
So there is when there is hyperglycemia, there is increased formation of sorbitol. So this sorbitol is very there's the permeability of the lens membrane is very low towards sorbitol, so it's remain accumulated. Moreover, the enzyme which converts sorbitol to fructose also has a lesser affinity for sorbitol, so it keeps accumulating. Sorbitol as well as fructose, they both keep accumulating and cause an osmotic effect, drawing in more water. Yes, sir. Sorry, sir.
Apart from sorbitol pathway, any other mechanism for cataractogenesis?
So the
Due to
remaining
diabetes.
So the remaining is almost similar to any age-related cataract, which is due to the oxidative damage of the lens proteins.
Anything related to dyslipidemia?
So particularly related with cataract or with diabetic retinopathy. Sir?
Yeah. Cataract.
No, sir, I'm not sure, sir.
On the recent study, which analyzed the triglycerides and diacylglycerol level in both serum and aqueous, and also in the lens. So these are all increased and correlating with the cataract in type 2 diabetes patients. Okay. So how to differentiate? Suppose a patient develops a cystoid macular edema and diabetic macular edema.
So the layers are different on when examined on OCT.
Clinically?
Clinically, sir, in diabetic macular edema, so there will be presence of hard exudates will be seen in and around the macula, whereas, sir, in cystoid, will not see hard exudates, sir.
So what is the appearance of cataract?
Sir, in diabetics, sir.
Yeah.
Sir, in diabetics, if there is more, it is more due to the hydration, we'll see cortical cataract, or if and in cases of young diabetics who have been remain metabolic who have had poor metabolic control for a really long time, we'll see snowflake cataracts, sir, which are also usually bilateral and subcapsular cataracts, sir.
Any other condition will have a snowflake appearance? Cataract.
Not sure, sir.
In Down syndrome also the appearance is similar.
Oops.
Will you go in for a multifocal IOL for such a patient?
No, sir. So, in a patient with macular pathologies, these patients are more likely to
These
the more
patients.
adverse effects with multifocal IOLs that are glare and halos are worsened in patients with macular diseases, sir. And also, sir, for any future examination for doing any laser or doing vitrectomy, it will cause difficulty to the surgeon also, sir.
So what kind of oil will you prefer for such a patient?
So I would prefer a hydrophobic acrylic lens, sir.
With the
Sorry, sir.
two more attributes that surgeons
Monofocal, sir. Monofocal hydrophobic acrylic lens.
hydrophobic acrylic. Square edge, yes or no? And yellow.
I'm not sure, sir.
Square edge will prevent PCO formation,
PCO formation, yes, sir.
and yellow will give some protection to the retina on the U side.
Yes.
These are the general considerations. What else will you advise this patient? You've done a fantastic job of getting the glycemic control and giving a good vision after surgery.
Yes, sir.
What advice will you give the patient for follow-up?
So the patient will be advised to follow up initially. The patient should be followed for monthly, and or will be advised to maintain a strict lifestyle habits and glycemic control. And then, and so we should also counsel the patient that since he had macular edema, so there are chances of his grade of diabetic retinopathy worsening in the eye that was operated for cataract.
How long does it usually take for the diabetic retinopathy to worsen after cataract surgery?
3 months, sir. 1 month. Not sure, sir.
And can it be as long as 1 year?
Sir, if the patient has a poor metabolic profile and continues with like deranged hyperglycemic levels, it will worsen early, sir.
Is there a chance that rapid metabolic control, like you did in 1 month for this patient,
Yes, sir.
can this lead to increase in diabetic retinopathy?
Not sure, sir.
Look up DCCT.
Okay, sir.
Dr. Manisha, you can ask, please.
Was to ask in the previous case, not allowed.
Dr. Nilima can ask few questions. Dr. Nilima, ma'am.
Yes. So I saw part of her presentation. Dr. Kirti, is it?
Ma'am, Kritika, ma'am. Yes, ma'am.
Dr. Kritika. Dr. Kritika, first of all, I'm happy that you all pick up the courage and present. That is very important. And I hope you learn things and take them back and, you know, apply them.
Yes, ma'am.
Read up about it. So your presentation was on cataract surgery with diabetic
And
retinopathy.
yes, ma'am.
All right. So what percentage of your patients who come up for cataract surgery,
Yes, ma'am.
have you observed them to have some grade of retinopathy along with cataract? Can you give us a rough presentation, a rough percentage, or can you even tell any recent data which you might have read about how many cataract surgery patients already have diabetes and retinopathy already present? Because that affects the prognosis, does it not?
Yes, ma'am.
So have you read up any data which has been any recent data, and what is your own experience of how many patients you see who need to undergo cataract surgery and already have retinopathy?
Ma'am, I have not read any data, but per se, patients with diabetic retinopathy, according to me, almost depending upon the age that they've been diabetic, if it has been like more than for 5 6 years and they have not been looking after it really well, like I think so, 65 to
No, no,
70%
no.
of.
That's not what I'm asking.
Yes,
I'm
ma'am.
asking when you have patients coming in for cataract surgery,
Yes, ma'am.
so how many of them may be having retinopathy already present, diabetic retinopathy already present? Is it common to have patients with cataract already having diabetic retinopathy? Because both are conditions of uh, elderly patients.
Yes, ma'am. And maybe 30% of ma'am who already have diabetic retinopathy, uh, but some majority of them, so, ma'am, they do are aware about their status. But I think so around maybe 20 to 30% are the ones which get a surprise when we do the fundus examination and they have some grade of diabetic retinopathy
What is
present,
the
ma'am.
first sign of diabetic retinopathy?
My first sign are microaneurysms, ma'am.
Where do you look for microaneurysms?
Ma'am, along the vessel wall, ma'am, there is an outpouching of it, ma'am.
Along the vessel wall, do you see them anywhere where there might not be an apparent vessel clinically visible?
Mm, Not sure, ma'am.
What other conditions can you see? Are microaneurysms only present in diabetic retinopathy or any other conditions where they may be present also?
In radiation retinopathy, ma'am. Not sure,
Hypertensive?
ma'am.
So
Not,
micro,
ma'am. In hypertensive, ma'am, we'll see hemorrhages, ma'am. Not sure, ma'am, whether we'll see microaneurysms per se, ma'am.
Dr. Kritika,
Yes, ma'am.
microaneurysms are not exclusive to diabetic
Yes, ma'am.
retinopathy. They may be
Yes,
present
ma'am.
in a host of other, especially vascular
Diseases, ma'am.
retinopathies. What is the best way to, how will you differentiate a microaneurysm from a dot hemorrhage?
We can differentiate on fluorescent angiography. The microaneurysm will show vascular leakage, not leakage. There will be hyperfluorescence, and whereas dot hemorrhage will show blocked fluorescence, ma'am.
Yes, very good. So dot hemorrhages will show hypo, whereas
Yes, ma'am.
microaneurysms will show
Hyper, ma'am.
hyperfluorescence. Okay, very good, very good. I think, as I said before, very important to present.
Yes, ma'am.
Thank you very much. All the
I think
best.
both have done a great job, both Dr. Kritika and Dr. Akanksha. And thank you so much for taking up the courage and giving such a nice presentation. And all the other postgraduates are also going to benefit from these discussions. Thank you so much to both the mentors for being here with their mentees. And thank you so much to our esteemed examiners also for sparing your valuable time and being here for us. It was a great discussion. Thank you, Dr. Prashant, for spearheading such a nice webinar.
Thank you everyone. Dr. Tanwar, Dr. Nilima ma'am, Dr. Manisha ma'am, Dr. Lognathan, and of course Kritika and Akanksha for sparing their valuable time. We are extremely thankful as a team ARC. So, postgraduates, it's time for us to wind up now. We'll be meeting on following Thursday again with some new topic. Till then, I think it's time for us to say bye bye. It's quite cold time, so let us all retire a bit early. Okay.
Thank
Thank
you
you so
very
much.
much. Thank you to ARC.
It was a very pleasant experience, and it was nice to see the young postgraduates take up the challenge.
Thank you. Thank you, sir.
Thank you so much, everyone.
Thank you.